Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. I have got the pleasure of introducing Mike Kingham, who are someone I work with and I have known for quite some time, working for Kent and Medway NHS Trust. Mike has got huge experience in working in the forensic field, and he's been quite supportive and we spoke a few times about supporting people in Sudan in terms of forensic practice there, forensic psychiatry practice. So when I asked him about this kind of coming to help with training psychiatry trainees, the work we've been doing since the start of the war, he didn't think twice and he jumped on the opportunity because I think he's very keen to help. If I just tell Mike briefly about the people who are the audience, who are in the audience, I think. So most of them, I think, are either psychiatry trainees or doctors working outside of Sudan. So just briefly, to give Mike an idea about the forensic practice in Sudan, I think there's no civil laws in terms of the Mental Health Act and stuff like that. And most people who are dealt with, people who are mentally disordered offenders, are dealt with through the criminal justice system. And there's quite a few number of, I don't know, call them low secure or medium secure units in Sudan. There's a big one in the capital, Khartoum. And I don't know whether we've got in the audience any of the forensic psychiatrists, but we've got quite a few people who work in that field, who work for the police. So it's not, there's no civil law governing kind of these issues. So without further ado, I'll introduce Mike, give him the platform, and I hope this will be helpful for everyone. Thank you.
Okay, thank you very much indeed, Ahmed, for asking me to give a presentation. And I'm delighted to do so, as you say. So I'll go straight into my presentation, if I may. Yasser, thank you. And I'm going to talk to you today about the risk assessment and management in terms of interpersonal violence and other forensic clinical risks from a forensic psychiatrist's perspective.
Yeah, I think there might be a problem, Mike. I don't know whether Yasser has been knocked out. His Zoom is frozen, so link. He just called me. So let's just see how we can sort this out. Hopefully he will. I'm quite sure he was now trying to log on again.
Yes, he's frozen, hasn't he? So
Yeah.
I'm happy to wait a couple of minutes for Yasser to return to us.
I'm back.
Excellent.
Well done. Thank you. So certainly you can go from onto the slideshow. Happy to do that. Thank you. We're going to go slide by slide. So just to recap what the definition of forensic psychiatry is, it's the assessment and management of patients who have mental disorder, who've committed serious criminal offences or who have the potential to commit serious criminal offences. I suspect from Ahmed's introduction that it's slightly difficult, slightly different in Sudan in terms of the way that the law is implemented with people being admitted to secure services after having committed a criminal offence. And it can also be defined as the part of psychiatry that deals with patients and problems at the interface of the psychiatric and legal systems. Okay, moving on. So in terms of the fundamentals of risk assessment, I'm going to be covering those first, and then I'll be going into risk factors for interpersonal violence, clinical and risk assessment, risk management, and then something about risk assessment tools. Right at the end, I talk about I touch on some other forensic clinical risks. And I look at interpersonal violence in the context of homicide and the National Confidential Inquiry that particularly focused on homicide as well as suicide up until 2018 in the United Kingdom. And so I'll be reporting on its findings up until 2018. So in terms of risk assessment, when we're talking about risk, we're talking about the likelihood or probability of an event happening. And I'm afraid in forensic psychiatry, that's usually an undesirable event. A risk factor is a variable that contributes to that risk, and a protective factor is a variable reducing the risk. And I'll be introducing these concepts later on as well, or going over these concepts a little bit more later on in the talk. So we could actually look at the risk of me failing to join today's meeting, and they would be a combination of me factors. So if I had a history of not meeting obligations, if I told Ahmed 10 minutes ago that I'm not turning up, that's clearly a risk for me not attending. There could be you factors as well. If I see the names of the group that'll be listening and watching this presentation, and I'm concerned that you're going to be intimidating, I might not turn up. If someone informs me that the session's cancelled. But there are environmental factors as well. And actually, we've experienced those, haven't we, in terms of me being able to use my computer to log on, and also Yassir having to rejoin after being ejected by the technology from the meeting. So if I'm delayed reaching a computer or the internet isn't working, both of which are quite likely, then again, that there are risks for me not turning up. And the outcome of all of that is that I might not join at all. I might join late, or I might have to telephone you to say that I'm unable to attend or that I'm going to be late. So if we look at that in the context of offending, we can see that there's an interplay of factors. So those that affect me as the subject, the factors that affect you as the object, or in terms of offending, a victim, and then environmental, contextual factors, external factors. And all of that leads to an outcome. Either I turn up today and give a talk, or I don't, in this context, but in the context of offending, whether an offence takes place or not. So moving on. In terms of expressing the risk, we want to know, is there a risk of harm? And if so, what sort of harm and to what degree? How likely is it the harm will occur? How immediate might it be? What are the factors that contribute to the risk, and how can those factors be modified? And I'd actually add another way of expressing this. Who is the likely victim in terms of to whom the harm will come? So what risks are we talking about in psychiatry? Well, of course, deliberate self-harm, risk of suicide, outweighs the risk of serious violence by many times. But when we're talking about forensic risk, we're talking about interpersonal violence, risk to children, sexually inappropriate behavior, sexual offending, fire setting. And then there are some secondary risks, like poor compliance and disengagement in themselves, which may lead to one of the primary risks described elsewhere on this slide. And escape and absconding is also a secondary risk as well, because in itself, it doesn't draw attention, but if an individual escapes from a secure service or a prison and goes on to cause somebody, to offend, then obviously that's a risk that needs to be prevented. Risk of vulnerability and risk of exploitation, two sides of the same coin. So in terms of now beginning to categorize risk, we can talk about static risk factors and dynamic risk factors. Static risk factors are those that once they're established can never change. For example, male sex at birth, or when it happens, previous history of violence. Thereafter, there's always been a history of violence, and that's absolutely static. The dynamic risk factors are those that can be modified and can change with the passage of time. And they can be subdivided themselves into stable and acute dynamic risk factors. And dynamic stable factors change in the medium to longer term. And dynamic acute risk factors arise more rapidly, but may be more amenable to intervention because they can go away more rapidly as well. So looking at the risk of interpersonal violence in society in the United Kingdom, I've set out here the risk factor and what category, in terms of the previous slide, they can be slotted into. So male sex at birth as a static risk factor, being in late adolescence or young adults, 16 to 25-year-olds, being a dynamic stable risk factor, age progresses slowly. Previous history of violence, which of course is a static risk factor, as I've just been saying, and substance misuse, which is a dynamic risk factor, and in terms of intoxication, is an acute risk factor. In terms of intoxication following use of the intoxicant, and then once the effects of the intoxicant is over, obviously an individual's no longer intoxicated. Also poor social circumstances, which are dynamic risk factors, but it can either be acute or stable. Yeah, thank you. Yeah, so just going in some examples here on this slide. So a static risk factor, as I said, being having male sex at birth, stable being a young adult, and acute being intoxicated, all of which lead to a greater risk of violence when you take the population into account, rather than a woman who's older, who's not intoxicated. So going on to the additional risk and protective factors that we need to think about for individuals with mental illness when we're talking about interpersonal violence. So we can divide these up into directly illness related, which are psychotic symptoms, particularly persecutory delusions, delusions of passivity, delusional jealousy, and command hallucinations, and anger and irritability that's directly associated with the illness itself. I would add to that impulsivity, actually, in terms of particularly agitated depressive states, or bipolar disorder, and irritable mania. So carrying on, these non-directly illness-related factors, I've put impulsivity in there. That's what this paper says. It's from a paper by Paul Mullen in 1997. I've given a link at the end of the presentation, so it's something that you can read at leisure. So those non-directly illness-related factors are plans for and fantasies of attack, that's impulsivity, poor social structures, and actually recent loss, although clearly that's a risk factor for suicidal behaviour as well. And then protective factors, somebody who's compliant with treatment, engaging with their clinical team, understands their illness and what they need to do to remain well. If their home circumstances are supportive, they don't have any motivation to commit violent acts, and they don't have any interest in or access to weapons. And as I say, that's a paper that I've given you at the end of this talk. Just a few papers on violence and mental disorder. So there's the Swanson ECA survey of, this is self-reported violence, obviously with the limitations that that has. But in the United States, 2% of people without any diagnosis said that they had been violent within a particular timescale. 8% of those who had a diagnosis of schizophrenia did so, and 13% of those with a dual diagnosis of schizophrenia and substance use. So that's a 1990 study from the East Coast of the United States. And then there's the MacArthur Violence Risk Assessment Study later on in 1998. Similar authors. They followed over 1,000 patients from the United States for a year following their discharge from hospital, and their rate of violence was 18% if they suffered from a major mental disorder alone, 31% if they suffered from a major disorder and a substance misuse disorder. Then coming across to the United Kingdom in 2001, the UK 700 study, which is a study of discharged patients with a diagnosis of psychosis over the period of two years, which found that 20% were violent. And all of the following factors had increased the risk ratio by about 1.5. Substance use, learning disability, victimization, which I think was defined as having been assaulted in the last 2 years, and previous conviction for violence and younger age, the things that we've been talking about already. But just to note here, again, that suicidal behavior outweighs interpersonal violence in our patients. Then we come to this meta-analysis that was published in the British Journal of Psychiatry in 2018, which took the papers that I've described and many others into account, and looked at odds ratios for violent behaviour over and above people without those risk factors. And again, you'll see a pattern developing here. Substance misuse, schizophrenia, and other psychotic disorders increase the odds ratios, as does bipolar disorder. It says here any personality disorder. I think that's a function of the meta-analysis, just taking all personality disorders. But I think if you were to take antisocial personality disorder, then you would shift that graph to the right. ADHD or hyperkinetic disorder is there, as well as traumatic brain injury. Those are the diagnostic domains, or neuropsychiatric, as they've described them here. Interestingly, epilepsy, which was much studied, and some myths became associated between epilepsy and interpersonal violence, was actually a protective factor. I don't know quite how reliable that is, but it crosses one, so its confidence intervals are that of the general include that of the general populations in terms of odds ratios. And then some historical factors with youth antisocial behaviour, being a witness or victim of violence in childhood, victim of bullying, being historical factors, and then other described as poor executive functioning, low empathy, and poor moral judgment that you may find on other rating scales that I'm not going to go into today in any detail unless I have any questions about them. So what did the National Confidential Inquiry in England find regarding homicide specifically? So we're leaving interpersonal violence and we're looking at homicide alone. And this covered the period 2006 to 2016, and that 89% of homicides by people defined as mental health patients. These are patients who are in contact with secondary mental health services in the previous 12 months. So 89% of those homicides had been in the context of alcohol or drug use. The victims were usually known to the patient, and stranger homicides are rare, being an acquaintance 47%, a family member 20%, and partner or ex-partner 18%, with stranger coming in at a lower rate at 16%. And almost half of patients, 48%, were either non-adherent or had missed their final contact with services. So poor compliance with medication or disengagement were highlighted as prequels to a homicide offence. This graph shows the number of homicide convictions in the general population in England alone, by the gender of the offender. So you can see that graph running along at the bottom, is female homicide convictions. The triangles above that are the male homicide convictions, and the squares are the total homicide convictions, and showing a reduction in from 630 in 2006 to 332 in 2016. Not quite a linear graph with that increase in 2008. But a trend clearly having been set. And remember that figure of 332 for 2016, because now we'll go on to the next graph, which is the number of patient homicides in England by year of offence and year of conviction. Lovely, thank you. So we're looking at about a tenth. So a tenth of the people who are convicted of homicide had been in contact with mental health services in the previous 12 months before the act, before the offence. And following a similar but perhaps more variable course. And then going on to the next slide. So what were the primary psychiatric diagnoses? They looked at secondary psychiatric diagnoses as well. But in terms of primary diagnosis, schizophrenia and other delusional disorders were represented at 34%, followed by drug dependence and misuse at 17%. They're all, as I said, in terms of secondary diagnosis, drug dependence and misuse were very prevalent in people with mental illness who were convicted of homicide. Then personality disorder, alcohol dependence and misuse, affective disorders, and other being 17%. So that's a bit of context as to violence in society, interpersonal violence in people with mental disorder, and then homicide in people with mental disorder. Then taking it down to the person who's in front of you, who you're assessing, the things we sort of know, we need to know in terms of history taking mental state examination and to start to be able to formulate risk is what happened, and that equates to the presenting complaint in terms of taking a history, and what were its circumstances equating to history of presenting complaint. Has it happened before? And then the mental state examination of eliciting evidence of mental disorder, which of course the history contributes as well. And then going on to decide, is there a link between what happened and the mental disorder? And then some risk assessment, beginning the embryonic risk assessment. Might history repeat itself? And might another event happen given the circumstances and the nature of the mental disorders? So in terms of the next slide, we need that history and mental state. So family history, development, education, relationships, work, social history, behavior and interests, psychiatric, physical and treatment history as an inpatient and outpatient, drug and alcohol history, forensic history, including the current offence, if there is one, and then mental state, particularly what we described before from those previous slides, those psychotic features, mood and emotional disturbance, and stated intended behaviour. And I anticipate that from taking the history and conducting a mental state examination, you'll be able to elicit, whether many of those risk factors, and indeed those protective factors, are applicable to the person in front of you. Collateral information is extremely helpful, and includes looking at previous records, looking at the criminal record, witness statements that pertain to the current offence, interviewing the person's relatives, interviewing staff who know the person, and then any psychological testing and physical investigations that have been done. So Maurice Weinstock, who works at Broadmoor Hospital, defined, and again, I've given links to all of the papers that I'm referencing today at the end. What we must do is ask the patient about any history of violence, ask them about current thoughts of violence, try to contact an informant and ask for that collateral information, look at the clinical records for the same, document the above, put the assessment together and produce a management plan. And again, we can actually substitute violence for any other risk outcome to be considered. So that's why I've italicized violence in the title of this slide. And then putting it together. So gathering the risk and protective factors and considering them as a whole. And contextualized by understanding the individual's family and social contacts, as well as their occupation and leisure patterns. And then producing a risk assessment from consideration of those factors and allowing the production of a risk management plan. What we've been talking about today so far is clinical risk assessment. We're not talking about producing an actuarial risk assessment that will give a percentage for a population in terms of a specific risk outcome over a particular time. But it's often that clinicians will talk about low, medium, and high risk, but then it's uncertain as to whether they're talking about the same thing. So this is actually a suggestion from the OASIS system, which is what probation service in England and Wales use. And it's a suggestion that I've made to colleagues and trainees down the years, is that if you set out that if you conclude that somebody is of low risk for a particular risk outcome over a particular timescale, you're saying really that there are no significant current indicators of risk. Whereas if you're setting out that somebody has a medium risk in that respect, then there are identifiable indicators of risk, but the risk outcome is unlikely unless further risk factors are added. And then high risk, which is that there are identifiable indicators of risk, that the risk outcome could actually happen at any time, and that intervention is needed to prevent the risk outcome from occurring. So moving on to risk management in the mentally disordered, we'll treat the clinical condition is the essential element of that. If you're diagnosed mental disorder with some of those risk factors associated with mental disorder and indirectly associated with mental disorder, then treating the clinical condition will reduce the risk. And then looking at those other risk factors and attempting to modify any that can be modified, remembering that static risk factors can't be modified and only dynamic risk factors can, and perhaps acute dynamic risk factors being more amenable to management, to clinical risk management, but not forgetting the stable factors as well. We do that either as an inpatient in terms of voluntary or detention, and then if someone's admitted, we have security elements that will manage the risk during their inpatient admission. We have chemical and physical restraint, rapid tranquilization, and also being able to establish medication in order to maintain treatment. Outpatient treatment relies on engagement, compliance or concordance with treatment, monitoring that, monitoring risk and encouraging the patient to avoid risky situations and optimizing their social circumstances. So, as I've said, I've talked today so far about clinical risk assessment, which is a descriptive risk assessment and a risk profile for the particular person, the particular patient who's in front of you, who you're assessing, and gives targets for modification. It doesn't generate a probability figure. Whereas actuarial risk assessments, which are used in the criminal justice system, are based on probabilities from statistical tables, adding factors together to give the probability of a specific outcome in a given time period for a large population. That is, X% of people with these risk factors will perform the risk outcome. But it doesn't say too much about the patient in front of you, and it doesn't give you an understanding of risk management either. So my suggestion is that we leave that in the sphere of the criminal justice system. But we can enhance our clinical risk assessment. We can bolster it with validated tools, such as the HCR20. So in the next slide, I talk about the HCR20 risk assessment for interpersonal violence, which is a structured professional judgment tool, which can anchor or modify our clinical assessment of risk, and actually gives us items, tangible items, to be able to assess risk from an item checklist, as it were, itemized checklist. And it lends itself to risk management methods. So there are 10 H items, 5 C items, and 5 R items in the HCR20. And I've equated those to static risk factors, dynamic risk factors, and speculative in terms of when we're trying to predict risk, we're not entirely sure what someone's circumstances will be 30 days, 60 days, 3 months into the future, but we can make a reasonably good estimation. So I'm not going to go through these in detail. HCR20 training is available. I've put a link to the HCR website in the appendix to this talk. So you'll see many of the factors that we've already talked about lighting up in the H values or the H items for the HCR20. Being previous violence, young age at first violent incident, relationship instability, employment problems, substance misuse problems, major mental illness, psychopathy, early maladjustment, personality disorder, and prior supervision failure. Then the clinical items comprise lack of insight, negative attitudes, and again that feeds into non-compliance and disengagement, active symptoms of major mental illness if they're continuing, impulsivity, and being unresponsive to treatment. With the risk management items comprising the person's plans lack feasibility, they're exposed to destabilizing influences, they have a lack of personal support, they don't comply with remediation attempts, and you can predict that they won't in future, and that they are subject to undue stress. So why do things go wrong? So we're going to go back to the National Confidential Inquiry and just look at homicide. And inquiries in the UK have highlighted similar themes, that clinicians have conducted insufficient information gathering, that there's poor communication between agencies. I said how important it is to look back at the clinical records and also obtain collateral information. There's a lack of consideration of previous violence, if there's no indication of it now, especially the failure to look back at previous violence, or to note warning signs to prevent or and manage relapse in clinical conditions, and failure to recognize and address other risk factors. limited resources and access to long-term care, and erroneous diagnostic substitution. Particularly, I think, individuals who've attracted a diagnosis of a psychotic disorder, who then get re-diagnosed as having a personality disorder, which then leads to services not engaging them perhaps as comprehensively as they would otherwise, and not prescribing the right treatment. Going back to the National Confidential Inquiry report, in the 2006 report, it particularly referred to the use of CPA. So CPA is the care program approach, which was a structured program of assessing clinical the person's clinical condition and social circumstances, and updating management plans and risk assessment and management. So the recommendations were to use that structure of the care program approach to make sure that care plans are updated, that any changes in the individual circumstances are noted, so that changes in clinical and risk management could be implemented. Using the higher level of monitoring and supervision for people who are assessed to present at higher risk, particularly those with severe mental illness in the early stages of illness. Jointly reviewing high-risk patients with other clinical teams, getting second opinions, essentially through local clinical governance, using modern drug treatments as first-line therapy to avoid the side effects, the unpleasant side effects of the older treatments that might deter patients from taking treatment and being compliant with treatment in the longer term. And also the development of dual diagnosis services, so managing mental illness and substance misuse, which is clearly important from what I've already described in terms of interpersonal violence and indeed homicide, and ensuring that staff are trained in substance misuse management. Responding when a care plan breaks down. So make sure that the people with severe mental illness and have a history of violence, or have been compulsory admitted under the Mental Health Act in England and Wales, or in their early stages of illness, or have dual diagnosis, receive the most intensive levels of supervision and monitoring. Re-establishing care assertively when a care plan breaks down, when someone stops medication or misses an appointment or both, and supervision entailing increasing frequency of contacts when necessary, and if necessary performing home visits, but certainly working with families. I'm just going to allude to sexual offending and then fire setting, because I haven't talked about them as yet, although many of the risk factors that I've described for interpersonal violence will apply to sexual offending and fire setting. It all depends on the person in front of you. But in terms of some additional specific considerations, assess when someone's committed a sexual offence, to assess their sexual preferences. For example, the description of fixated or regressed paedophilic interest, illicit cognitive distortions that remove someone's disinhibition and allow them to, which allows them to offend in their own mind, clearly not according to law or social convention, but for themselves, those cognitive distortions that give them permission, they believe, to offend. And of course, diagnose any mental disorder if it's present, particularly considering delusions, command hallucinations, disinhibiting factors, and errors in consequential thinking. There's a structured professional judgment tool that's really it's established and validated. The risk of sexual violence protocol, which is commonly used in the United Kingdom in forensic mental health services. And then fire setting, for which there isn't such an established or validated tool, although there's a lot of research going on at the University of Kent, which we're affiliated to in the NHS Trust that I work for. So in terms of fire setting, consider the motives. Clearly, that there are some motives that are not so associated with mental disorder, such as financial and revenge motives, but then some that are more associated with mental disorder, such as when fire causes arousal, including sexual arousal, when fire is a means of attempted suicide, or a maladaptive call for help, or indeed accidental fire setting as well. And once more, look at assess the person for mental disorder, consider delusions, command hallucinations, disinhibition, errors in consequential thinking, and cognitive impairment, particularly in terms of accident. And then at the end, I've given those references and some links to useful resources. Thank you very much for listening. I'm happy to take any questions.
Yeah, excellent. That's very, very helpful and very clear. So I will open the platform, open the chance for anyone who's got a question to ask Mike. People should raise their hands, maybe, if I can see them in the list and ask any questions. Yeah, Yasser.
Right. Thank you very much for this very excellent presentation. Just a question about risk assessment, because it's supposed to be done for almost every patient with mental illness, inpatient or outpatient. But one of the things that comes to my mind, especially with the practice of risk assessment, in the case we encounter a patient with a substantial history of violence before, a patient who assaulted staff, a patient who assaulted other patient, let's say in the inpatient unit. I've seen that practice before, where especially in the emergency level, with electronic medical records, where they put a mark or a label or a reminder that this patient has a history of violence. And sometimes this is supposed to be intended to do is to help with management. However, it has been used actually for discrimination and for treating patients sometimes inappropriately. What's your thoughts on how we can manage this?
Yes, it certainly is a double-edged sword. A previous history of violence certainly needs to be recognised for people who are assessing and treating the individual the next time around. But it may have been 20 years before and in very specific circumstances with dynamic risk factors that aren't at play in the present. So I think education of staff in terms of those dynamic risk factors, and not just looking at a history of violence, but taking that into account, and the nature of the violence, as you say, but contextualizing it and ensuring that those dynamic risk factors and indeed those dynamic protective factors aren't lost, because they're very powerful. And need to be taken into account for someone's current presentation, and to lose sight of that, which it happens on not uncommonly, unfortunately, then causes stigma to arise unnecessarily. So it's about having one's wits about one when assessing the individual and the way that they're presenting at the moment. Clearly, if they're presenting in the same way as they did back then it raises concerns, and a higher level of vigilance, really, in terms of conducting the assessment safely and making sure that the management plan is commensurate, is proportionate to the risk assessment, but not automatically inferring that the patient's going to present like that as they did, as is noted in that sort of highlight, when nothing more is known about them.
Yeah, thank you. Ahmed Mukhtar.
Yes, thank you. And thank you very much for sort of helpful and exciting presentation. I'm just wondering whether there are sort of comparative studies on other culture about the link of mental disorder and risk, and also about your views about the use of HCR20, which is a validated tool in sort of European and American sort of countries in non-European and non-American sort of countries. Thank you.
Yeah, thank you. Really, really good questions. I mean, you'll see that my talk is rather US, but especially UK centric, and I think it's fair to say that many of the risk factors and protective factors that I've described are generalizable. But I'd be looking to you actually to ask you in terms of the cultures that you know whether it rings true. And yes, HCR20 is validated in Canada, US, Europe, and that's my bread and butter really. I'd be really interested to hear from the audience as to your views as to whether it's applicable more widely, including to your cultures. Yeah, although many of those factors that I've described are, I think, likely to be generalizable.
Does anyone actually know whether HCR20 is used in forensic settings in Sudan?
I mean, if I may come, I mean, well, I did work in Sudan in psychiatry, but that is a while back, and it wasn't used at the time. And I have had conversation with colleagues who had been working until very recently, and it is not, as far as I can say, it is not used. But there may be people who are more contemporaneous than me who can add to that. But as far as I'm aware, it is not used. Yeah.
Yeah, I think yes. I think before we can answer the question whether it's culturally sensitive or not, I think we need to have some experience of using it. Is it? And then maybe we can generate then those type of questions. I've got Abdulazim raising his hand, but before Abdulazim comes in, because I've got a question just following from Ahmed's question, and my question is about morbid jealousy, because I think it is a culturally sensitive kind of. I don't know if there's any literature about that across culture, how it presents, because I think it's probably one of those problems that people don't, in terms of doctor assessing risk, people don't ask about it, and if you don't ask, you don't get the extent to this kind of problem sometimes. And so it's only when you ask the question, then the floodgate opens in terms of all the symptoms, you find them there. This is my experience here. I don't know about the experience in Sudan because I didn't work there, but I would have thought that it is something that's probably quite significant in terms of risk, especially risk to women. And it's not really a question, but it's just kind of a statement. And just wanted to know that anyone has got any idea about that or experience themselves in terms of.
I can say a little bit about it, Ahmed, because I don't know if you know, but I wrote a review article on morbid jealousy in 2004 for Advances in Psychiatric Treatment. And that review article takes evidence from all around the world, not in a systematic way, but in a sort of way that focuses on where the papers have been written. And morbid jealousy does seem to be a fairly universal affliction. And it is a very substantial risk factor for violence, being a delusional illness, particularly against one's partner, or not as much, but still significantly against the alleged paramour or paramours as well, who the individual accuses the partner of having affairs with. And actually, From time to time, I do Google that paper, and it is quoted in a number of jurisdictions from particular criminal cases that have occurred in those jurisdictions internationally. But again, I haven't sort of listed which countries or the types of report.
Does anyone have any comment to make about this, or shall we move on to Abdulazim's question? We shall move on to Abdulazim's question. Okay, Abdulazim.
Sorry, good evening. Thank you very much, Ahmed. Thank you, Dr. Kingham, for this nice and very informative talk. I really enjoyed it. My question is from your experience as a forensic psychiatrist, I think one of the challenges they face forensic psychiatrists is the transition of the patients from inpatient units, especially I'm talking about patients who committed high-profile crime, homicide or attempted homicide. The challenges of moving this patient eventually to the community after spending a period of time in inpatient. What is the factor, or at what point that you decide that this patient should now be released in the community? Number one. Number two, my question is, I don't know if there's a study about that or just from your experience. What is the percentage actually of patient, let's say, who committed homicide that eventually will be released to the community? What percentage of those patients will be ready to be moved to the community? This question is important actually in other cultures like Sudan and Arab East, is just because there is deficient in community services in this country. And this challenge always face people to move people who spend long years as inpatient to move them to the community. So just need your opinion on that. Thank you very much.
Thank you. That's a really, really good question. So when to release or discharge? Essentially, when you've minimized those risk factors and you've absolutely maximized those protective factors, that you can be as certain as you can be that not only is somebody well, that they're committed to continuing to take treatment, not to disengage, and not to indulge in destabilizers, those contextual factors that cause their mental state to deteriorate or for them to offend in the first place. And we do that in secure hospitals in the United Kingdom through not just optimizing the drug treatment, but using psychological treatment, occupational therapy, and monitoring people's response to that to maximize those protective factors and minimize the risk factors. And in parallel, what we do is we gradually increase their access to the community. So first, they'll be granted escorted community leave with the number of with members of staff and the number of staff that you consider is appropriate to manage risks that may emerge in the community, which you will have already predicted from the patterns of their risk beforehand, and then leading on to the very significant stage of unescorted community leave, so that when someone accesses the community unsupervised, following usually a substantial period of escorted community leave, and taking the observations of staff into account when considering applying or granting them unescorted community leave, as well as their behaviour on the ward, in terms of what they do when they're alone, what they do when they're in the company of other patients, and and how their relationships with staff are. When you're certain, as sure as you can be, that throughout all of those stages, and with all the improvements that they've made in terms of minimizing their risk factors and maximizing their protective factors, can discharge be considered. And then, of course, as you've already said or indicated, discharge isn't the end. It's very much the beginning, really, because it's important that there's a well-resourced aftercare and expert aftercare to detect when those risk factors might be increasing or those protective factors might be slipping, in order to be able to make a risk assessment whenever any of those factors change, especially if they change for the worse. And we're fortunate in the respect of being able to discharge people to supported accommodation, which itself is staffed. Now, it may be staffed only during the day in some circumstances, but other accommodation is staffed 24 hours a day. And it's really a calculation as to whether that person needs this supervision, the support, supervision and monitoring of staff around the clock, or only during the daytime, that you make the decision as to whether to discharge them to which level of care. In terms of the number or the proportion of people convicted of homicide who are released or discharged into the community, it's actually the vast majority of people do get released or discharged, but only when all of those checks and balances that I've described have been have been fulfilled, and there's usually quite stringent legal examination of a decision to discharge, well, often it's a legal panel that decides whether to discharge or release a patient. So if someone's in prison, then it would be the parole board, and if someone's in hospital, it would be a mental health tribunal. And for certain prisoner patients, it's both a mental health tribunal and a parole board hearing. So it's stringently managed, I would say, but it's the majority of patients who are admitted to hospital who have been convicted of homicide will be discharged, but under those very careful conditions and having been through treatment to modify their risk factors and to establish that that's the case over a long period of time.
Yeah, any more questions for Mike? All right, so it's been an hour, and it's been a pleasure to have Mike, and we're so grateful for him to have the time.
Sorry, I think there's somebody raising his hand.
Yes? Okay.
There's a hand raised.
Hassan
Hassan
Al-Lamin.
Al-Lamin.
See that.
Thank you so much. Thank you for the insightful presentation, Dr. Mike. I really appreciated the valuable information you've shared. I have just interconnected questions here. So how do we navigate the balance between the patient confidentiality and the need for the risk disclosure in our assessment? And at the same time, what kind of strategies we can employ to communicate this risk assessment findings effectively to the patient and their respective network?
Yes, thank you. Someone once said there's no such thing as confidentiality in forensic psychiatry, but I don't agree. I don't agree with that. Our patients have the same right to us keeping their information confidential as any other patient. Balanced against that is the risk to the public of serious harm of not disclosing information when it's necessary to do so. So when there's a situation where a patient presents an immediate risk, and you're not in a position to manage that risk for example, by locking the doors of a hospital and not giving them leave for an inpatient, in other circumstances, then it's our duty to take every step to protect the public from harm. And we should do that. In terms of managing risk in the ways that I've just described, really, for someone who's being discharged to the community, it's a question of engaging. This goes to the second part of your question, really. It goes to engaging the patient in a frank discussion about risk, and to be able to set out what you think their risk factors were at the time of their offence, and what protective factors had slipped away, weren't present. And it's important to reach some sort of agreement. You don't have to agree entirely as to what the risk factors were and what the protective factors were, but you need to be in the same area. Because what happens then is a discussion about what disclosures are needed in order to help them to move through their care pathway. So, for example, supported accommodation that I was talking about, needs to know about what happens when things are going right for the patient and what happens when things are going wrong, so that intervention can happen at an early stage in order to stop a risk outcome from happening with the least restriction possible. So that might mean a change in medication, or the solving of a difficult social situation, an interpersonal, a situation of interpersonal conflict, for example, or turning someone around from the early stages of substance use. And in the majority of cases, patients who are on the journey towards supported accommodation will agree to having that really important information disclosed to people who can help them do something about any emerging risk.
Yeah, but thank you, Mike. Got a question from Amra Tahir.
Thank you, Ahmed, and thank you very much, Michael, for the incited lecture into forensic psychiatry and risk assessment. I'm just going to want to make a brief comment about the HCR20 and culture, because we actually tried to introduce HCR20 in Qatar here. 3 years ago, we started we done a couple of courses for the forensic services and intellectual disability services. And as far as kind of I can say, obviously there's no research here, but from my experience or our experience here in Qatar, we think as long as kind of the team who's completing the SCR20 are fully aware of all the different cultural kind of issues and circumstances for the patients, so they will be able to kind of complete the comprehensive assessment and they complete the SCR20. We have formulated a number of cases, but I think, yes, research might be needed in this area. And maybe Hassan Amin, who just asked the question, he's a fellow forensic psychiatrist who can take some of this work further. My brief question to you, Michael, is about intellectual disability as a psychiatrist in the field. I wonder if we are seeing more of the cases of neurodevelopmental disorders coming into forensic, and whether you can tell us as well a little bit about if there are any specifics need to be considered in the risk assessment around those disorders. Thank you very much.
Thank you. Again, it's a really excellent question. Yes, we're seeing more and more people diagnosed, in my experience, with autism spectrum disorders, but not necessarily a full diagnosis, as it were, but with traits of autism spectrum as well. And that affects the way that they communicate and the way they behave. And it certainly needs to be incorporated into risk assessments in terms of their particular behavior, especially stereotype behavior, if that lends itself to criminal behavior, for want of a better term, and fixated interests as well, or fixed interests. That are stereotype as well. Also responses to people who are trying to engage them, and particularly restrictive practice as well. And I won't generalize, but those are areas in which it's really important to conduct a full assessment of that individual's particular patterns, whether they've been diagnosed with autism, or whether they've been diagnosed with traits of an autistic spectrum disorder. Absolutely. I think there's more awareness of neurodevelopmental disorders, and I think that's why there's a move to more diagnosis.
All right. Any more questions? No. So we're coming to the end of this. We're so grateful for Mike for finding the time to be with us, and I hope this is not the last time. And I hope sincerely that we will one day have Mike with us in Sudan, so he can meet with our colleagues working in the forensic services there, and he can see Khartoum, and he can see the River Nile and the blue and the white Nile where they meet. I genuinely hope that will happen one day. So if there's no more questions, so we will bring this to a close, unless Mike wants to say anything at the end.
Well, Ahmed, as I say, many thanks for inviting me. I've thoroughly enjoyed it. I'd very much like to visit Sudan. Thank you, everyone, for listening and for your excellent questions.
Excellent. Yasir, anything you want to say? You still there?
No, just thank you very much for the excellent and wonderful presentation.